So this presentation will be in two parts. We'll first discuss the development and implementation of an ERAS pathway at the MNH, and the second part will be understanding the implementation process using an implementation science framework. So we're really using the ERAS pathway as an example to discuss how things are implemented. First, I'd like to acknowledge, I won't name everybody on this page. A lot of people contributed to the development of the enhanced recovery pathway that we're going to be discussing. In particular, I want to mention Dr. Diaz because he's played a key role in the development and implementation. Also, Kira will be presenting work that she did in collaboration with some McGill students, Connie Wong and Zoe Kurczynski. So for our first part of the presentation, the learning objectives are to understand the purpose, core elements of an ERAS pathway, and then how these ERAS components can be applied to craniotomy for malignant brain tumor. And then we'll look at the adherence to the different components at the MNH. So first, what are ERAS pathways? For those who aren't familiar, ERAS pathways are the systematic application of best practices at every phase in the perioperative trajectory. They're based in the evidence and patient-centered. So we're trying to get away from, individualized care trajectories based on physician preference, but rather developing a consensus with the team and going forward with the best standards we can come up with for a patient population. Key pillars of ERAS include patient and family engagement, nutrition management, fluid and hydration management, early mobility and physical activity, pain and nausea management, as well as surgical best practices. These are really the ERAS principles that were applied to any enhanced recovery surgery pathway for any type of surgery. And of course, there's individual components depending on the patient population and type of surgery. So pathways are developed by a multidisciplinary team, including surgeon, anesthesiologist, internal medicine, nursing, pharmacy, members of the allied health team, and the exact composition of the team will depend on the population. The development process involves first selecting a relatively homogeneous population because we want to make sure that the patients on the pathway do have very similar needs, and then looking at every single aspect of the patient's care that they've received during, or before, during, and after the surgery. ERAS pathways have been shown time and again to reduce complication rates, shorten length of stay, cost savings, and improve patient experience. Something that's a little bit underexplored in the literature is what they can do for clinician experience. So in looking at that, there aren't a lot of studies that discuss that, but there was one that was interesting that I would like to share, which was done on a colorectal unit. So their aim was to look at nursing workload specifically on after implementing an ERAS, it wasn't an ERAS, after implementing ERAS on the whole colorectal surgical unit. And they did a mixed method study. They looked at nursing workload in terms of quantitative time and motion data. And then they looked at nursing perceptions and see how did people feel about their workload and what was their perception of a change with the addition of ERAS. It was interesting that the workload data, like the quantitative time and motion study, actually showed that there was a higher turnover of patients on the unit because they were more successful in discharging patients quickly, and they were actually doing more tasks with patients. So the time and motion study would have, you might say, increased the nursing workload. However, actually nurses' perceptions were that it decreased their workload. So I think that's interesting, and it really speaks to the ability of ERAS pathways not to actually diminish the type of the tasks of in care that are provided, but rather to streamline workflows, enhance communication among the team, reduce administrative burden of documenting, et cetera, which can lead to, I would hope, improve clinician satisfaction, but that would be an interesting area of study to explore further. So why did we choose the malignant brain tumor population? Well, the main reason was because of the fairly high volumes at the neuro and compared to other populations. Also fairly elevated complication rates. So this data was from 2022, 2023, 13% having infections, 9.7% with seizure, hemorrhage 8.7%, thrombophlebitis 3.6%, and about a little bit less than 10% returning to the emergency department or being readmitted. So we aim to reduce complications mainly. And then, of course, we're hoping that by reducing complication, maybe we'll reduce length of stay as well. So I'm not going to spend, so we're going to go through the EROS guidelines applied to craniotomy for malignant brain tumor patients. And I'm not going to spend a lot of time on this area because we really want to focus on the implementation of the pathway. That's the focus of our presentation today. I will touch on it, however, and go through relatively quickly just to make sure that we know what the intervention is. Can you see my little pointer? Okay, so this is sort of a summary of the care pathway. In the preoperative phase, anyway, this works too, I guess. Yeah, preoperative phase, we have while the patient's waiting for surgery, due to their cancer diagnosis, patients with malignant brain tumor are at risk for malnutrition. So we want them on a high calorie, high protein diet, and that actually helps with prevention of wound complications. There's a patient education booklet that was adapted for the pathway, which has information for the patient about how to take care of themselves and optimize their health before surgery. Some screening for malnutrition, etc. I'm not going to go through everything because, again, I want to move it along. If any of you have questions about the actual pathway, I do have copies of the pre-printed orders in my office. I will go and get them, and you're welcome to ask me questions afterwards, and we can discuss. So for the day before surgery, we're trying to steer away from the classic NPO after midnight order. Most patients benefit from, of course, being no food, dairy, juice with pulp after midnight, but the morning of surgery, actually having a glass of juice. We have updated the skin antisepsis protocol to, instead of using those the pink bottles of pink with chlorhexidine in them, soap, thank you. Instead of using the pink soap, yes, because the bottles are not pink, I get it, is washing with regular soap, then apply chlorhexidine wipes, and apply chlorhexidine wipes again in the morning without rinsing it off. The thromboembolic stockings were not demonstrated to be more useful to add thromboembolic stockings underneath the SCDs. So for most patients, just the SCDs is fine. Also, we're not in the habit at the Neuro of providing preoperative medications, but in fact, it's a really good thing to do for a lot of surgeries. So in the pathway, we added the option for pre-op Tylenol for short duration cases for the surgeon to order, and pre-op aprepitant, specifically for patients who are very much at high risk for post-op nausea and vomiting due to the location of their tumor. So it's posterior fossa and interventricular tumors, which aren't that many patients, but for those patients who do get the aprepitant, it really makes a big difference. So after OR, we are focusing on pain and nausea management. There's some specifics in the pathway here that I won't get into. Blood sugar monitoring is very important, specifically, well, for any patient going through surgery, major surgery, but actually particularly brain tumor patients are on high-dose dexamethasone often. So this is a critical component. And essentially, the reason that we care about blood sugar is because it almost, actually, Dr. Diaz did a study a couple of years ago, and he found that when the perioperative blood sugar was not well controlled, it actually doubled the risk of infection, or there was a correlation. They were twice as likely to develop an infection. So that's the main reason, but there are other complications too that can occur, even for non-diabetics. Dysphagia screen, again with a high calorie, high protein diet, discontinuing NS as soon as the patient is able to hydrate by mouth, up to chair for meals, usually on post-op day 0. And we also discussed with the multidisciplinary team that in the goal of having mobilization occur as soon as is possible on post-op day 1, that the registered nurse can do an assessment, and if everything is fine, they could initiate the mobilization, walking. Keeping STDs in place for longer than most other patients because of the risk for DVT being very high due to the cancer diagnosis. And continued on, there's some teaching in the patient education booklet. Removing Foley in the early morning helps to prevent, it helps with 2 things actually. It helps to prevent urinary tract infections, but we're not seeing a lot of urinary tract infections with our brain tumor patients. But I also imagine it would help with early mobilization, right? The fewer things is better. Removing the dressing post-op day 2 and leaving the incision open to air. I know that this was something that the different physicians before had different practices. So now at least it's more standardized. And then washing like with soap and water, the hair on post-op day 5, etc. Okay, so moving along. Okay. So the implementation strategy, now we're getting to the meat of it, because this is what we really wanted to discuss. So we started with some lunch and learns in February 2024. At that point, hoping that we were going to implement the pathway like within weeks after. There ended up being a long delay, which points to certain barriers in the development process that I won't get into, but it did have to do with the language, presentation, and how things would be scanned, et cetera. Anyway, so it took a whole 6 months to resolve, which is unfortunate. So we had some delays there, and we actually did the lunch and learns twice. So I think there were, anyway, a series of delays that were unanticipated, which I think did influence our implementation. So I will mention. In September 2024, we started with in-services. All the residents had an in-service with Dr. Diaz. I was able to reach 60% or 65%, a little bit less than 70% of inpatient nurses and licensed practical nurses with about a half-hour in-service session in person. Then for those that weren't able to be present, we had a short video, I think like 15, 20-minute video that nurses could watch. We also had a meeting in the pre-admission clinic. There was a meeting with the OR team. And yes, that's about it. Oh, also an SDA and PACU had some in-services. Then in October, end of October, was our go-live date. And my initial plan in the follow-up of that was to go around and follow the patients through the pathway and speak with the nurses taking care of the patients to see how things were going. And actually what ended up occurring was that the patients weren't on the pathway. So there were issues with the papers getting to the charts, which yes, we had thought out a plan of how things would go, but it didn't turn out the way that we had expected. So there were issues with papers getting to the charts, that sometimes the physicians weren't using the pathway. So it ended up really being around like January, mid-January, I would say that things like improved and there was more use of the pathway. So I'm going to go through the adherence to best practices. And I did a chart review. Like I said, that because the uptake wasn't so quick in the beginning, I didn't do an audit in the beginning because I was pretty convinced I wouldn't see any difference. So I started the audit mid-January to end of February. There were 24 patients, and actually only half of them are on the pathway. So you see, we still have a ways to go. So at each component in the pathway, some had excellent adherence. The discontinuation of Foley at 6 a.m. Was great. Discontinuation of dressing post-op day 2, no TEDs under SCDs. I still put this under good adherence because I know there was an improvement soon after. The chlorhexidine wipes. Early mobilization is really tough to tell by chart audit, actually. But I said in 67% of cases, there was some mention in the nursing notes of how the patient was mobilizing. Excellent adherence. I noticed that in 67% of cases, there was some teaching that was mentioned in the progress notes. Just to note, the 33% where they didn't get teaching, I noticed they were mostly going to rehab or long-term care. Not that the discharge teaching is still equally important, but I noticed a trend there. And I also think it's amazing that we did really good with our blood sugar monitoring. I'm happy to hear about that. And areas with lower adherence. So the high energy, high protein diet was not always entered into OASIS. Pre-op juice, interesting. So here in the gray, that's when the physician actually opted not to order the pre-op juice, either because there was a contraindication or the physician perhaps wasn't comfortable. I'm not really sure. I didn't dive into it further than that. But there were some cases where it wasn't ordered. And then here in orange is when it was ordered, but it wasn't actually carried out. And here is where it was carried out. And then Tylenol pre-op, we can see that it was probably underprescribed. Although again, it's possible the patient, there was a not contraindication, but if it was a long duration surgery, then it's possible they chose not to order it. And then we also noticed that sometimes there was an omission and it wasn't actually given when it was ordered. And the post-op, and I won't go into detail here, but the post-op multimodal pain management strategy wasn't optimized either. So many of you are probably familiar with the PDSA cycle model of quality improvement. This process of continuing to monitor, plan, make changes to either the product itself, or in this case, the implementation strategy is so critical. In healthcare, we're constantly evolving. There's always some new best practice coming down the pipeline to implement. So it's really quite easy to neglect or to follow up on a project when a new one comes in. And that's when backsliding occurs, or when you don't even achieve the initial results that you intended to achieve. So knowing this, I was so pleased when Kira approached approached me with her coursework on implementation science because I felt it was really relevant to helping to kind of see, okay, what, not just what could have been done better so that we could do it in the future, but also what can we do now? There you go.
You, Heather. So, as part of a knowledge translation course, I put together a project that focuses on the barriers and facilitators surrounding implementation of the ARS care pathway at the MNH. The reason for choosing this topic is because of my personal experience of witnessing the launch of the protocol late last year and then never hearing about it again. I'll be sharing with you the reality of the care pathways implementation on the floor through the perspective of nurses. So our learning objectives, we have, we're going to understand the purpose and core principles of implementation science, apply the IPARS framework to assess ARS implementation, and evaluate the barriers to ARS implementation and propose facilitators that can address and overcome in clinical practice. So what is IS, or implementation science? It's a study of how to apply research and evidence-based practices in real-world settings to improve the quality and effectiveness of health services and care. Today, I'll be focusing on the dissemination part of that process and how we share and apply the ARS pathway with our team of neuroscience nurses using planned practical strategies. So what makes a framework in IS useful? Well, it helps researchers and clinicians identify key barriers and enablers, guiding the development of effective strategies for successful implementation. There are many frameworks in implementation science that guide us to thoroughly understand what internal and external factors influence the implementation success or its failure. These frameworks are often grounded in psychology, sociology, and organizational theory, helping us explore not just what needs to be implemented, but also how and why it succeeds or fails. Examples are the CFIR, so the Consolidated Framework for Implementation Science, the TDF, the Theoretical Domains Framework, amongst many others. Today, we're going to look at the IPARS framework, so the Integrated Promoting Action on Research, Implementation, and Health Services. It was originally developed in the late 90s, and it was revised in 2016 by Harvey, McCormick, and Kitson to reflect that implementation isn't linear, but in fact, it's dynamic and relational. IPARS blends research with real-world experience, recognizing that what works must fit the setting and people involved. It defines success as achieving project goals by facilitating innovation tailored to recipients within their specific context. The framework focuses on 4 core constructs, so the innovation, recipients, context, and facilitation construct, where facilitation is the active ingredient in the process, and it assesses, aligns, and integrates the 3 other constructs when developing strategies. I'll explain each construct as we go through the barriers. So the first construct, we have innovation, which would be ARAS in this case. So ARAS is a protocol that blends formal research with practical on-the-floor knowledge, adapting evidence to fit our specific setting. So it's usable, realistic, and effective in daily practice. Now, I'd like to walk you through the barriers that we face on the floor. So the first would be the second construct would be, The second construct is recipients, where it looks at both the individuals and the teams and focuses on their attitudes, behaviors, and the time, support, and resources that they need in order to engage in the change. So the first barrier would be resistance to change. And we can see this with our staff, so physicians, nurses, patients, families. We've seen surgeons actually crossing out new orders of ERAS and reverting to traditional post-op instructions. As Purcell and its colleagues in 2015 note that some physicians are actually hesitant to change due to habit. And nurses are guilty of this as well. Sometimes they may resist when protocols disrupt familiar routines. Another interesting, and then we have patients, especially post-op, and understandably, they can be hesitant about early mobilization. They fear it may harm their recovery and cause too much pain. And this is really where, this is really when education becomes critical. So on to our third construct, which is context, referring to the setting where the change is taking place. And it's divided into two subcategories. So the inner context and the outer context, where the inner context is the immediate local setting. So your unit, the hospital, the primary care team. And this is one where we have more control over compared to the outer context, which I will discuss shortly. So our first barrier under this construct would be the readability and design of the PPO, so the pre-printed orders. It's a more technical but real barrier, and this is the layout of the ERAS PPOs, like I mentioned. So we have the bilingual formatting, English on one side, French on the other side, but upside down. I mean, it can be really confusing having to turn a bunch of pages and flip them like upside down to be able to know what needs to be done. We also have the slot labeling of ERAS PPOs at the nursing station, specifically on 3 East. The slot for ERAS documents right now is labeled BT. Most of us here know, I would assume, stands for brain tumor, but this acronym isn't recognized by new or recent graduate nurses. I know through colleagues that have been here at the Neuro for several years are familiar with it, but this is not the majority employee staff in our high turnover environment. So there's a lack of clear labeling. One of the facilitators, I know we haven't gotten there yet, but we can put ERAS in it, or like ERAS hyphen BT, because there's not even a mention of ERAS. So then now we're gonna look at the outer context barriers, and this construct refers to the broader healthcare system, which includes the policy, social, and political structures that influence the inner context of care delivery. And this is where we have a little bit less control over, as I mentioned before. So we have lack of organizational support. So unlike other surgical specialties at the MUHC, ERAS for craniotomy, for malignant brain tumors at the Neuro doesn't have its own page or policy support on the hospital website. It sends a message, whether it's intentional or not, that ERAS at the Neuro isn't fully recognized or prioritized at the organizational level for our patient population. And lastly, I saved this for last because it likely won't come as a shock to anyone, but we are suffering from persistent understaffing, high turnover rates, and junior staff with limited experience, which make it hard to consistently apply ERAS practices. You can add into the mix frequent sick calls and unsafe nurse-to-patient ratios further reduce this capacity. Nearly every article I reviewed for the purposes of this project pointed to lack of time due to high workloads as the most consistent challenge to implementation across various clinical settings internationally. So after that long list of barriers, on a more positive note, I want to shift our focus onto the facilitators, what's working for us and what could work better. So the last construct would be facilitation, and this is the core ingredient, which involves the processes, tools, and leadership strategies used to align all these elements that I mentioned previously to help assess needs, tailor strategies, and build capacity for change. So in our context facilitators, to address the barriers I mentioned previously, we have prompts and reminders. Better visual cues and quick reference guides on the unit would be beneficial. Since we don't see craniotomies every day, it's hard to build that natural familiarity with the pathway. Having reminders embedded into our workflow, like posters on the unit, ERAS reminders, and emails in the weekly nursing newsletter can reinforce the key steps and make the process easier to follow. Then we have the streamlining of the pre-printed orders. One thing that could really help here is redesigning the ERAS pre-printed orders. Even something as simple as checkboxes, color coding, or a one-page layout in a single language could help us use the form more efficiently during a busy shift. Ongoing education and training. We can offer workshops, refresher sessions for nursing staff and PABs, along with a virtual ERAS teaching session that staff can complete on their own time. This ensures that part-time, full-time, weekend, and night shift staff all have access to the training. Then we have continuous quality improvement. So through audits and feedback, monthly or quarterly audits to check whether ERAS PPOs are being used appropriately. These audits are not punitive. They're actually a tool to identify gaps and offer feedback in a supportive way. This kind of ongoing reflection supports trial and learning, empowers nurses to suggest improvements, and promotes multidisciplinary collaboration. It also addresses barriers like lack of awareness, motivation, or knowledge, because people are more likely to engage with something when they feel seen, supported, and involved. Clarifying rules. So clarifying rules promotes team engagement and pathway adherence, educating PABs on their responsibilities, such as assisting with feeding, mobilization, performing pre-op skin prep, and applying SCDs post-operatively, to name a few. This reinforces the impact of their role on patient recovery. Additionally, right now, our unit coordinators, our UCs, are responsible, well, they make these pre-admission booklet packages, but they're really tailored for neurology patients. So if you have a neurosurgical patient that's scheduled for surgery, a lot of those documents are already missing from the get-go. So a way to facilitate that is to involve the UC in preparing two separate packages. So one for the neurology patient and one for the neurosurgical patient. Nursing leadership at the point of care. So leadership makes a big difference, and we're lucky to have such strong support here at the Neuro. Heather Perkins, our advanced practice nurse, has been instrumental in ERAS's success since the protocol launch late last year. She's been right there with us, offering hands-on support, educating the team, and serving as a credible leader. And with Dr. Diaz backing it from the surgical side, we've had a strong united front. Lastly, so one of our strengths is that the MUHC is already an ERAS leader, while the Neuro was one of the last to adopt the pathway. Other sites like the MGH actually have a dedicated ERAS unit that was initiated in 2023. This existing system-wide familiarity can help drive adoption here. And to support this, we need stronger institutional visibility, starting with a dedicated ERAS neuro section on the MUHC website to boost institutional visibility, awareness, and engagement. So I posted pictures of what the MUHC ERAS website looks like, and I added neuro. So while the barriers are real, the facilitators are just as strong and they're within reach.
Great. Thank you, Kira. So before I present this slide on what we're currently doing to enhance the implementation in the short term and what we plan to do, I want to just take a moment to reflect on some of the key lessons, like just my personal key reflections from my conversations with Kira, also from feedback I received from various different people when I was going out actively seeking feedback over the last couple of weeks from residents, nurses, members of the nursing leadership team over there. So my key takeaways, because I want to first think a little bit about just the initial implementation, because thought did go into how, the implementation, but there are some things I would do differently in the initial implementation. So I want to just go through them. One, the first thing that Kira mentioned to me was that it was, implemented and then nurses didn't really hear much about it for a while. And I think that the reason for that on my end was that I felt like, well, because when I was following up on it, the papers weren't in the charts. It wasn't actually being done. So I felt there was nothing to say to nurses, but actually there was. I could have at least given the feedback that like, okay, this is coming. We're working on this. We're working on that, and a little refresher. So I think like just in terms of lesson learned there, I would do that in the future with a different project. So also, I love the implementation science framework that Kira used, like the IPARIS framework, which talks, when she goes over the environmental aspect of it, had we been using a framework like that, we might have considered the environment differently. For example, we may have asked the question, where are the patients actually going after surgery? And then, they're going to we don't have a dedicated unit just for brain tumors, right? They're going all over the hospital. So what that tells me is that like the tools really need to be super user-friendly, super easy, and super simple, because one individual nurse may not get a patient on the pathway all that often. And another reflection I had, which was that actually at the time that ERAS was implemented, other things were being implemented at the same time. So something we can also do is just look and have sort of a master calendar, for example, to look at all the things that are being done at the same time, or try to avoid having things being done at the same time. Okay, so on to what we're going to do. First of all, regular audits and refreshers, offering short quizzes. So what's been ongoing right now over the past couple of weeks, I've been sharing the audit information with nurses, going through just sort of a refresher of the whole pathway and going through a few tips based on the audit results. So that's been ongoing over the last couple of weeks. Sort of at huddles, and also we shared a video in the newsletter last week, and we'll probably share it in other different ways as well. Just a short video of the same thing that we did during the huddles, along with a short quiz. And we do have a plan in the short term to increase the readability. So initially, my plan was to gather feedback on all of the clinical component, as well as readability component, and then do an update. But that would take a long time before we sort of fix this issue with the readability. So I discussed with the chair of the CPRC, and we're going to do it in 2 stages. So I have a plan for improving the readability. Also, in my I got a lot of feedback verbally this time around, but for the next phase of improvement, I'm going to ask for feedback in a written way. Why? Because I realize that sometimes if it's something that I can change myself, I will happily do that. But if it's something that I need to advocate with, it's kind of nicer to have it written down. So I might do like more feedback written next time. And then as things go and people are more familiar with the pathway, instead of doing refreshers on the entirety of the pathway, hopefully it can just be like quick tips based on the audit results. And these should be frequent prompts and reminders and ongoing surgical engagement with the surgical team as well. So this is the plan. Thank you, everybody.
Thank you.
One second. We have a conclusion statement. And that's it. Thank you. We stay for questions. Yeah.
Are there any questions?
Yeah,
Okay. In fact, I would like just to make a few comments. I've been working with patients, brain tumor patients coming directly to the PACU, especially during the night if they're staying. So what I have observed is that there are some orders that are they are contradictory, on the ERAS and on the pre-op, post-op orders. Sometimes they are contradictory. And also all the physiotherapists also involved in the ERAS for the mobility post-op. This is just a question actually. Just like a stroke patient, they come and assess the patient on the first day post-op.
So the way that the multidisciplinary team was involved was more in the development phase, and that's where we discussed with OT and PT to discuss the first mobilization on post-op day 1. They are actually involved in the pathway in the sense we created, yes, actually, I'm forgetting. At the time of development of the pathway, we created a collective order for occupational therapists and physiotherapists for seeing the brain tumor patients automatically without a consult. So they're involved in that sense, and they see the patients, and in that collective order, it says they see the patient on post-op day 1, and that they also see the patient, if they're admitted prior to the surgery, they would see the patient. So they're involved in that way. The SLP we didn't involve them in the collective order because we had a discussion about it with management. They decided not to because they don't actually see all of the patient and it would increase their volumes. So initially when we developed the collective order, we had to sort of prove that they were already seeing 99.9% of the patients anyway, and that it wouldn't change the workflows. I don't know if that really answers your question, but we didn't get into specifics of what they would do with the patient, if that makes sense. So, it rather just timing of seeing the patient. Yeah.
No, actually, it will help, especially if they are new nurses, if they are already assessed by the physiotherapist, they will feel more confident in mobilizing the patient and knowing about their weaknesses. I think that would help a lot in that sense. Also, from what I find is that the patient they're a little bit reluctant to mobilize just because the pain control, the pain is not controlled. And also sometimes, especially elective patients, if they're coming for the surgery, if they are not aware about what's going to happen to them, if the pre-op clinic also can explain to the patient a little bit more, because sometimes I find when they come, they are more should I move? Should I do this? They are a little bit more reluctant. So I think that if they are educated more, that would help a lot, actually.
That's such a good point. And I know, so we have our patient education booklet. It's given in the pre-admission clinic, and the nurse will review what she can with the patient. But from my very brief exposure to working in the pre-admission clinic myself, I think with the brain tumor patients, that time for when they get told that they need surgery and then they actually come in to be admitted can sometimes be very short. And sometimes in that clinic, they're anxious, and there may be a little bit of so sometimes it depends on the patient. The information given to the patient is really tailored to their state of readiness in that moment. So in the pre-admission clinic, if you have a patient who's super willing and wants to talk about everything, you go into that post-op stuff, use your inspirometer. Mobilization is super important. Use it, that will happen if the patient is in a state where they is in a good place to have that. So what I noticed, and in my brief exposure to working in the pre-admission clinic, was that it's, I don't know, a lot of the patients, you really need to focus on what they need to eat and drink before surgery and the skin antisepsis, and give them the booklet and say, please bring this with you to the hospital. And then the nurses will review it with you on the unit because the state of anxiety is so high. So it's case by case what's done in terms of education.
So much.
Any other questions? Perfect. Thank you.
Thank you, everyone. So we do have a 30-minute break right now. It's our lunch break. At 12 o'clock, we will have a presentation by Amal Bouya, who will present on rare neurological disorders. It's about 30 minutes. So after that, you'll have another 15-minute break. Okay, so first 30-minute, go grab your lunch. You can eat in here. You can eat in the Healing Garden, just across from the auditorium if you've not been to the neuro before. And please, please, please start filling out your eval form. So if you scan the QR code behind your name tag, you can start filling out the first 3 speakers. Okay, and it's a requirement for accreditation. Okay, so if you want your 6.5 hours, please fill it out. I will monitor. And please put the name that you actually want on the certificate. Like, don't just put James. Put James Pigeon if you want your full name. Okay. All right. So see you back here at 12. Feel free to network, get to know each other, or stay in your groups, whatever you want. No, there's more. Guys, there will be another lunch coming up, okay? It's not just what's on the table. Okay. Yes, it's in the link. Yeah. If not, just email me the eval. So if you scan with oh, it's yes, 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 yes. Yeah, yeah. Makes sense? Perfect. One second.